Look, let's be honest. When you think about global health, you probably picture heroic doctors in far-flung villages or scientists in pristine labs having a eureka moment. You think of selfless dedication of humanity coming together to fight disease, and that's a lovely, heartwarming image. It's also dangerously incomplete. Because behind every vaccine, every public health guideline, every hospital bed there is a mountain of money. A massive, complicated, and often deeply troubling pile of cash that dictates what gets done, who gets helped, which crises get ignored. It's the silent, invisible force shaping life and death on a global scale, and we almost never talk about it. Which is insane, because if you want to understand why the world responds to one pandemic with lightning speed and lets another fester for decades, you have to follow the money. Tonight, we're going on a journey into the bewildering world of healthcare finance. We're prying open the piggy banks of the organizations you trust to keep you safe. We'll be looking at the World Health Organization, or WHO. We'll scrutinize the U.S. Food and Drug Administration, the FDA, and we'll even peek behind the curtain at your local hospital. All right, let's start with the big one, the World Health Organization. The WHO is supposed to be the world's health leader, the coordinator-in-chief for global health emergencies. You'd think an organization with that much responsibility would have a stable, predictable budget, right? Wrong. So wrong. The WHO's funding is essentially split into two wildly different buckets, which is a bit like funding a fire department with a combination of a small fixed property tax and a series of unpredictable bake sales hosted by billionaires. On one side, you have assessed contributions, and on the other, you have voluntary contributions. Think of it as the difference between your reliable salary and that one time your weird uncle gave you $100 for mowing his lawn. Assessed contributions are the membership fees that all 194 member countries are required to pay. The amount each country pays is calculated based on its wealth and population. It's a bit like a global gym membership where the United States pays a whole lot more than, say, Tuvalu. This money is the WHO's core funding. It's flexible, predictable, and can be used for whatever the organization deems most important, from paying the light bill at its Geneva headquarters to funding long-term projects that don't have a flashy, marketable hook. It's the boring, essential cash that keeps the entire operation afloat. The problem? It's not nearly enough. Then you have the other, much larger bucket voluntary contributions. This is money that countries, philanthropic foundations, and other organizations choose to donate on top of their required fees. And when I say it's larger, I mean it's colossally larger. For the 2022 to 2023 budget cycle, assessed contributions made up less than 20% of the WHO's total funding. It means the WHO has to spend a huge amount of its time and energy acting like a global charity, hat in hand, asking for money. This two-tiered system creates a fundamental instability at the heart of the WHO. The organization can count on its small pot of assessed funds, but the vast majority of its work depends on the whims and priorities of its donors. If a rich country or a massive foundation suddenly decides they're more interested in, say, funding a new interpretive dance initiative about the plight of the pangolin, a huge chunk of the WHO's budget for something like polio eradication could simply vanish. Now we arrive at the giant, glittering, treacherous mountain of cash known as voluntary contributions. This is where over 80% of the WHO's money comes from, and it's where things get really complicated. These are donations given by member states over and above their required fees, philanthropic organizations, other UN bodies, and the private sector. The top donors in this category are often the same countries that lead in assessed contributions, like Germany and the United States. But right alongside them, you find non-state actors with immense influence, most notably the Bill and Melinda Gates Foundation. That sounds great, right? More money for health. But here's the catch. The vast majority of this money is tightly earmarked. A donor doesn't just write a check to the WHO General Fund. Instead, they say, here is $50 million, and it must be used exclusively for this specific polio vaccination campaign in these 3 countries, and you must report back to us every 6 months with these specific metrics. It's less of a donation and more of a contract. The WHO becomes an implementing partner for the donor's pet project. This has a profound and distorting effect on the WHO's priorities. The organization's agenda is no longer set solely by the World Health Assembly based on global need. Instead, it's heavily influenced by what's fashionable among donors. Diseases that have powerful advocates and clear, measurable outcomes, like polio or malaria, tend to attract massive funding. Meanwhile, strengthening entire health systems, which is less glamorous and harder to quantify, gets chronically underfunded. Okay, let's bring it home to the United States and talk about the FDA. The Food and Drug Administration is the agency responsible for ensuring the safety of, well, almost everything. Your morning cereal, the prescription drugs you take, the sunscreen you put on your kids. It's a monumental task. You would assume, therefore, that this critical agency is funded entirely by the American taxpayer. And if you assume that, you would be adorably, tragically mistaken. The FDA's funding is a strange hybrid model, a mix of congressional appropriations and something called industry user fees. Historically, the FDA was funded almost entirely by money allocated by Congress. But starting in the early 1990s, things began to change dramatically. The agency was facing a growing backlog of new drug applications, and critics, particularly from the pharmaceutical industry and AIDS activists, argued that the approval process was too slow. The solution proposed in 1992 was the Prescription Drug User Fee Act, or PDUFA. This was a landmark piece of legislation that essentially created a deal. The pharmaceutical industry would pay user fees to the FDA to help fund the drug review process. In exchange, the FDA committed to stricter timelines for making approval decisions. The idea was to give the FDA more resources to hire more reviewers and speed things up. And it worked. The fees provided a massive influx of cash. For the 2023 fiscal year, the FDA's total budget was about $6.6 billion. Of that, only about 55% came from congressional appropriations. The other 45%, nearly half its budget, came directly from the industries it is supposed to be regulating. For the Center for Drug Evaluation and Research, the part of the FDA that actually reviews new drugs, the numbers are even more extreme. There, industry user fees account for roughly 2/3 of the budget for drug review. Let me just repeat that. The people who review the drugs we take get most of their funding from the companies who make those drugs. All right, let's move from the global and national level right down to the place you actually go when you're sick, the hospital. If you thought WHO and FDA funding was weird, get ready for the American hospital system. Funding a hospital is like trying to run a 5-star restaurant where most customers don't pay with weird coupons from hundreds of different companies. Some are legally required to be served even if they have no money at all. It's a chaotic, mind-bendingly complex financial ecosystem. The primary source of revenue for most hospitals is reimbursement for patient care, but reimbursement isn't simple. Most comes from third-party payers: Medicare, Medicaid, Blue Cross, United Healthcare, Aetna. Each negotiates secret rates with hospitals, deductibles, co-pays, payments from the uninsured, philanthropic donations, federal and state grants, parking garages, gift shops, cafeterias, side revenue that keeps things afloat. Hospitals hire armies of billing specialists and create a charge master, which is why an aspirin can cost $30 on a hospital bill. To really grasp how differently these crucial health organizations are bankrolled, it helps to put them side by side. Looking at the World Health Organization, the FDA, and a typical U.S. hospital. The World Health Organization relies on assessed contributions from member countries for about 18% of its funding, while a whopping 82% comes from voluntary contributions by donors like the Gates Foundation. The FDA, on the other hand, gets around 55% of its budget from congressional appropriations, with the remaining 45% coming from industry user fees, which are much higher for drug review. A typical U.S. hospital draws 60 to 70% of its revenue from Medicare and Medicaid, 20 to 30% from private insurance, and the rest from out-of-pocket payments and donations. When it comes to financial flexibility, the World Health Organization has very little. Its core funds are flexible but tiny, and most funds are heavily earmarked by donors. The FDA risks regulatory capture because of its heavy reliance on industry fees. Hospitals are left to deal with unpredictable revenue and sky-high administrative costs. That creates vertical programs, AIDS, TB, malaria, which can be effective but often at the expense of horizontal investments, functioning clinics, trained healthcare workers, robust supply chains, and public health surveillance systems. For the FDA, industry user fees create subtle pressure, a cultural shift from cautious watchdog to collaborative partner, with performance metrics that prioritize review speed. That has pushed the FDA to rely more on preliminary data and surrogate endpoints, expecting post-market studies that are often delayed, poorly designed, or never completed. We've learned that the organizations we entrust with our health are not the pure, independent bodies we might imagine them to be. The problem is the system itself. The financial architecture of global and national health is deeply flawed. It creates perverse incentives, distorts priorities, and undermines independence. We need to demand more public funding, more transparency, and fewer strings attached. Because when it comes to safeguarding human health, the bottom line shouldn't be the bottom line. Our lives literally depend on it. Look, this stuff is complicated and it's infuriating, but ignoring it doesn't make it go away. If you found this even a little bit eye-opening, follow us, subscribe, do whatever it is you do. Now, if you'll excuse me, I need to go lie down. My brain hurts.